Hi everybody, good evening and welcome to our second GECCo Classroom. Before we start, I was just going to go over some housekeeping rules. So please remember to keep your microphones on mute during the presentations, and when it comes to participating, we want to encourage people to raise their hand via the Zoom function until you're chosen to unmute, or alternatively, if you have any thoughts or questions throughout, please feel free to put it into the group chat and we'll involve as many of you as possible throughout the evening. If you do fall out of the event, please just click back on the link you were sent via the email and you'll be readmitted. So thank you. So quickly, just to introduce myself, I'm Dr. Jessica Gray, and I'm currently a medical trainee for Leeds Teaching Hospitals. And I have an interest in global healthcare systems, particularly emergency healthcare systems outside of my experience within the NHS. The Leeds emergency consultant, Dr. Najib Rahman, directed me towards the Royal College of Emergency Medicine framework for Global Emergency Medicine Fellows last year, which has provided the structure for this 4-part series. We're fortunate enough to also be introduced to Dr. Anisa Jafar and the Global Emergency Care Collaborative, also known as GECCo, which is a national open platform for multidisciplinary professionals who have an interest in emergency care, but also global health, whatever the stage of their career or level of experience. So this classrooms concept is to introduce the basic concepts of global emergency medicine, and is a kind of a birth child of myself and Dr. Fenby Hodgson, a colleague at Leeds Teaching Hospitals with an interest in public health. And this will also be facilitated by one of our emergency medicine colleagues, Dr. Jessica Oscroft. Following this presentation on emergency care systems, we'll hear a case study in a bit more depth to help demonstrate some of the reality of implementing such a system. And then we're incredibly fortunate to hear from one of our emergency care physician friends, Dr. Gabin Mbanjumucyo, who's currently working at King's College London and has done some interesting work in Kigali, Rwanda. And then we'll also be meeting Dr. Melinda Narendra, a consultant in emergency and internal medicine at Blantyre, Malawi. So this is the schedule for today. This will be the second of a 4-part series to introduce global emergency medicine over the next year. Following the guidance of Global Emergency Medicine Fellowship Framework, this second session will do a brief overview of emergency care systems globally, particularly in low resource settings, and how this knowledge is part of the foundation of understanding the global emergency care systems. By the end of this presentation, we hope that you'll have an understanding of what emergency care is comprised of and highlight the importance of having an emergency care system, to also understand the barriers to accessing emergency care. And I cover some of the resources available with strengthening emergency care systems, as well as some of the key learning points and challenges faced when developing them from the literature. So emergency care encompasses from pre-hospital care to hospital facilities, and this can include access to help in the community, safe transportation, appropriate triaging of patients, and then subsequent evidence-based management in a dedicated healthcare facility. Emergency medicine is a relatively new specialty, but a very important and evolving one. And as covered in our first session in June on disease burden, disease and injuries that require emergency management accounts for over half of disease burden globally, but also for over half of the deaths that occur in low to middle income countries. Recognition of emergency care is globally increasing and has been building momentum. So to briefly touch on some of the background, in 2018, the $3 billion goal was a 5-year plan with 3 strategic priorities as shown on the diagram, aligned with the Sustainable Development Goals. And this was agreed on by the World Health delegates at the 71st General Assembly. And then this was recognising that strengthening an emergency care system was a huge component of this initiative's success. Then later on that year, in December, there was a launch of the Global Emergency and Trauma Care Initiative, which sought to increase capacities to provide emergency care in the countries and improve global awareness. And this encouraged that assessment of pre-existing systems to identify gaps in delivering emergency care and then implementing proven interventions. Development of national plans and policies to ensure universal access, implementation of World Health Organization standards, such as implementing a triage protocol or tool, and World Health checklists, such as the trauma checklist. and data collection on patient cases and management to form a globally accessible registry. As mentioned, it's been recognised that emergency care systems play a really important role in achieving the Sustainable Development Goals, but particularly looking at Sustainable Development Goal 3, which is good health and well-being, and 11, sustainable cities, and 16, peace and justice. The following year, in 2019, the World Health Organization General Assembly, the Director General submitted an emergency and trauma care report, further reiterating the importance of emergency care systems in achieving these Sustainable Development Goals. And this highlighted that emergency care systems are often the first point of call for many who don't have access to primary health care in the community, regardless of background, but even those most disadvantaged or marginalised. And that most recognised interventions for emergency diseases and injuries are time dependent and only most effective if delivered in a time-sensitive manner. Recognise that there are discrepancies in outcomes when comparing more developed emergency care systems to those in lower resource settings, such as with diabetic ketoacidosis, where mortality rates are less than 1% in high income settings, whereas in lower resource settings it has been reported to be as high as 30%. Also recognise that high impact changes can be implemented at a low cost, and this could be something like a pre-hospital protocol to ensure transport to the appropriate facility, say if they need neurosurgery and need to be transferred to a tertiary department, or even triage protocols to enable prioritisation of care. And we cannot keep on improving patient outcomes without understanding the emergency care system already in situ. So data collected can help resource allocation and policy changes, and consistent documentation then enables further quality improvement in the future. And lastly, a well-designed and resilient emergency care system is less likely to destabilise when inflicted to additional pressures such as a mass casualty event or a pandemic. And then in this case, there is direct mortality from this said event, but there's also preventable mortality known as a secondary mortality from delayed access, assessment, treatment of everyday presentations. So this was a really interesting infographic shared in 2018 by the World Health Organization showing that the emergency care system, which I think is quite a good visual description of an emergency care system. So this was designed to support policymakers to strengthen national emergency care systems, and it's a reference framework showing all the essential functions to help identify gaps in care delivery in order to then develop action plans from there. So each stage of the framework's journey is dissected into primary functions, what components are involved, what human resources and training is required, what equipment is required, the data that can and should be collected from these interactions to aid research, and what protocols and laws are relevant. So this picture really does say 1,000 words. So the framework will actually be addressed in more detail in one of our future parts of these series about health partnerships. However, I do feel like this leads quite nicely into looking at the actual patient journey, from whether they have a national number to call a dispatch for transport, all the way to the actual patient flow in the hospitals and the capacities there. So to understand the patient journey, we initially have to look outside of emergency medicine. Thanks to the initiative of the Millennium Development Goals and then subsequently the Sustainable Development Goals, which focused quite specifically on maternal mortality and subsequent maternal health specific goals, we can see improving statistics in both high and low income countries since the 1990s, which really reflects this global collective effort. However, medical and surgical emergencies account for more global burden than maternal illness. So arguably, we could approach emergency medicine and other public health issues with the same successful approach that we approached improving maternal health. This 3-delay model was adopted and then adapted from maternal health research, which focused on 3 main factors that affected outcome emergencies in pregnancy. And it recognised that chronologically, there were 3 main moments where a delay may occur in a patient's journey with an emergency condition, with multiple interwoven social factors that can affect each time point. However, these factors aren't specific to obstetric emergencies, but can actually be applied to emergencies in general. So if we were to look at the first delay point, where a patient decides to seek care, there's obviously a large number of patient factors that could be involved. But if we were to look at a few, there's perceived societal status, whether this be affected by gender, class, education, or personal finances. There's recognition of the illness and the severity of it and what may actually be the cause of this. And then recognition that this illness may require an intervention and that this intervention is accessible. And lastly, that the perception of care quality. So even if this intervention is accessible, where they access it from, do they see that there is a quality of care there that they want to go and be provided? Delay 2 is a patient identifying and then reaching that healthcare facility. So geography actually plays a huge part in this, and there's several countries around the world where a large proportion of the country's population live rurally. There's a few initiatives to try and combat this. So in Ethiopia, over 3/4 are living rurally. And over the last couple of decades, they've successfully implemented a health extension programme with health extension workers based at more local health posts to try and improve that outreach for primary care in these communities. But also means about looking at access to transport if they do need emergency care and the ability to afford this said transport. The weather, if the country has had any first responders or pre-hospital services implemented previously, and the road infrastructure, which hugely determines the type of transport that would actually be appropriate. And lastly, delay 3, which is receiving adequate and appropriate care, which can be affected by communication barriers and patient illiteracy, patient compliance and adherence to care, which can be affected by their religious or socio-cultural beliefs, affordability of the care, if there's a triage system to prioritise those who are sickest, the human resources, staff training, equipment available, and if transfer is then required to a specialist facility, like I mentioned earlier, say for something more specialist like neurosurgery. So now we've covered the patient journey, I want to focus on some particular aspects of the emergency care systems themselves. So traditionally, service improvement has had quite a vertical approach, which is very disease or department focused, i.e. with obstetrics or trauma. And like this house depicts, the collective minds focus on one area to improve, which makes it easier to obtain funding and measure outcomes, but there is minimal impact on the surrounding associated specialties. However, a horizontal approach is a more comprehensive approach and focuses on developing a whole integrated system. Often this means instead of directly targeting one issue, it takes a more broad-based approach, such as prevention or education, with the aim to address several issues, but is understandably harder to implement and then also measure. So both approaches are valuable in strengthening emergency care systems, but for this evening, we'll just mainly cover a couple of aspects: pre-hospital care and triage. So pre-hospital care globally can be categorised into 4 types. That's lay people, police transport, basic life support trained, advanced life support trained, or physician-led. And in areas that have actually a developed emergency medical service already, they've either adopted the Anglo-American model, scoop and run, which is mainly staffed by paramedics, or the Franco-German model, stay and play, which is largely staffed by physicians. The difficulty here, though, is there's quite limited research in the area of pre-hospital care. Most research in pre-hospital care is in trauma care as well, since the global burden of road traffic accidents is increasing. However, despite 90% of this burden being within low to middle income countries, a 2017 systematic review demonstrated that over half of the research was from the same few low to middle income countries. This is highlighted by the darker red on this map. So one could argue that in countries without an established pre-hospital care, the scoop and run approach should be emphasised in order to reduce the time to definitive treatment. This has been achieved in some countries by introducing a communication system and improving transport, and particularly has been seen some success in obstetric and paediatric cases. However, it's difficult to say whether the speed to the facility has been the main reason to see improvement in mortality rates, as it appears that several studies that also introduced transport and communication also introduced provision of basic life support to paramedics, but also those in the community. There's a specific case study that we'll be covering later, which looks at simple life-saving measures that could be taken by the community care providers And this case is based in northern and central Iraq, where long transit times were inevitable. Like the chain of survival that we know well with out of hospital cardiac arrests, it's recognised that a similar approach is required with trauma, and that's with early first aid, early life support, early treatment and early rehab. And this study reportedly, by using this approach when implementing pre-hospital care, saw a significant decrease in patient mortality, despite this study actually spanning over the early 2000s when the country was inflicted by war. We'll cover this in a bit more detail later. Then if we look at emergency care facilities, particularly in low to middle income countries, as is everywhere globally, demand often exceeds resources. Which is why it's important to prioritise those sickest who need treatment more urgently, and this process is known as triaging. In some countries, there isn't an established process to identify those most sick, and this is made more difficult if you then don't have access to equipment to check observations. Many deaths actually occur within 24 hours of arrival within an emergency department, so arguably some of these may be preventable if you can identify those sickest sooner. And this has actually been emphasised further during the COVID-19 pandemic, how important and effective triage is. Before we move on to any other points, I was just going to look at two examples of some triage aids that have been used in low resource settings. So around 15 years ago now, the World Health Organization and UNICEF suggested this triage approach for children in resource poor facilities. It looked at emergency signs, which were these signs mentioned at the top, which required, if they were notified, required immediate management, say oxygen or a fluid bolus, and then escalation immediately to a clinician. Whereas priority signs weren't as much of an emergency, but definitely needed escalation immediately, but didn't need immediate treatment. And then all the other patients could wait in time order and be sent to the waiting room. And then this concept was built on a little bit further and more recently in 2020, where the World Health Organization, the Red Cross and Médecins Sans Frontières collaborated to form a 3-tier system for resource-limited emergency care systems, which was initially released as actually a recommended tool during the COVID-19 pandemic. So this just highlights that clinical acuity really decided where the best location was for the patient. So those with emergency signs or very high risk vital signs would be moved to a dedicated resource area where the appropriate equipment and staff were available for those sickest. They also recognised that those non-urgent concerns could wait in the waiting room, but that often these issues can be dealt with quite quickly if there is someone dedicated to that area, hence the patient can be seen in fast track, but that's if the staffing allows. So back to emergency care systems. Other than triage, education of the public, but also staff has a huge positive impact. But obviously it must be appropriate to the local context. Therefore, we can't just duplicate a successful protocol or procedure from one country to another and expect that it will take off. We also have to recognise that there is a lack of essential resources in some healthcare settings. Around 20 years ago, an observational study of some low to middle income countries around the world found that there was a lack of supplies and with 50%, less than 50% of district emergency departments not even having access to oxygen, adrenaline, salbutamol, and really essential emergency department supplies. And if they were available, most hospitals required prepayment before administration, or the medications needed to be acquired from the patient's family from a local market, which obviously then delays treatment further. And lastly, as we kind of touched on in triage, the physical layout of a department really aids the reduction of overcrowding and encourages patient flow. And there was quite an interesting read from 2020 of the lessons learned from redesigning a hospital in Haiti. However, for many countries, a designated emergency department or a resuscitation area is a novelty, and finances play a huge role, but it's an aspect that definitely needs to be considered if we're going to aim to globally strengthen emergency care systems. So in summary, this was a bit of a whistle-stop tour. Emergency care systems are much more than just an emergency department, and emergency medicine is much more than just trauma, maternal and paediatric health. There is guidance out there and some examples of implementation of emergency care systems if you're interested in reading further. However, an ideal emergency care system on paper may be affected by several patient factors like we addressed, and this may hinder universal health coverage. And each emergency care system is case specific, and you can't just replicate successful models from one country to another with these different patient demographics. But lastly, there's definitely need for further research in this area. So these are a few resources that I came across quite early on in my project, which I felt would be quite useful. And at the bottom, there's a link to recommended World Health Organization tools that they recommend for strengthening emergency care systems. But I can also pass on any reference used in the slides if anyone's interested.
Thank you very much, Jess. So I think we're next moving on to Beth, who is touching on one of the things that Jess was talking about of pre-hospital trauma. So she's going to be talking through a paper and a case study. So I'll pass you over to Beth.
Great. Thanks, Jess. So my name's Beth, and what we're basically going to be doing tonight is having a look at this study, which is basically about the implementation of a pre-hospital care type system into Iraq. Now, don't worry if you haven't had a chance to have a look through this study beforehand. What I'm going to do is spend a little bit of time looking at the actual study, but then spend a bit more time thinking about some concepts around this kind of research area that the study brings up. And that's kind of thinking about ethical considerations around research design, and then also kind of highlighting the importance of local context as well. So we'll start by having a look at the actual study. So it's a cohort study, and it's set between 1997 up to 2006 in Iraq. And it starts out in this little red circle here, and then it's expanded into the green circle, and then expanded again into the blue circle. It mainly looks at trauma victims, so those impacted by landmines, and then road traffic accidents, and then also other war victims as well. Predominantly young male population, although there are some female and paediatric patients as well. And the intervention itself, like Jess was explaining about pre-hospital care, was actually pretty simple. It's where the authors trained local paramedics in how to provide pre-hospital trauma life support. And they also taught the paramedics to kind of be able to teach local lay people about basic life support as well. And they ran some 2-day courses in the local areas. Data was collected looking at trauma, the severity of trauma, the type of trauma, and then also deaths as well. And this was collected using some pre-validated scores such as the International Severity Score and the Physiological Severity Score as well. And that was collected kind of on site of the trauma, in transit, and then in the hospitals afterwards. And probably not unsurprisingly, they showed that implementing this system reduced the pre-hospital mortality rate. And they kind of did this by looking at the pre-hospital mortality rate prior to the study, and then at each kind of time period as well. So that brings us quite nicely to the first thing that we're going to think about, and that's about ethics. And that's because, as Jess said, we know that pre-hospital care systems generally improve mortality and morbidity. And because we know that, it means that we have to be careful about how we design our studies. Now, because of ethics, if we know that an intervention is going to work and work really well, we ethically can't run a randomised control trial, which is obviously the gold standard for an interventional study. But obviously, we still need to be able to research these areas as well, and we still need to be able to check that what we're implementing is actually working, and also working as we want it to. And so there's a few different ways to do this. So the first thing to think about are kind of historical controls. And that's basically where you start with population A, and then you apply your intervention and you look at the same population again. And that means that the population can act as its own control. And that's kind of what they've done in this study when they've looked at the, they've done the surveys before the intervention. The second thing you can do is something called geographical controls. And this is where you have population A and population B. And for whatever reason, population B might not be able to have the intervention for kind of practicality, feasible reasons, etc. And that can then act as a normal control. However, there is also another thing that's called stepwise progression, and that's shown by this little diagram down here. And that's actually becoming quite a common way of looking at service implementation. And it's basically where you start out with lots of little discrete populations, such as cities, towns, villages, etc. And then over time, you slowly roll out your intervention. And this means that the populations that are yet to receive the intervention can act as the control for the populations that have. And obviously, all of your populations will eventually get the intervention. And this is also, again, what the authors have kind of done in this study with the different time period expansions. The other thing you can do is something called opportunistic controls. And that's because if you roll out an intervention amongst a population, you're very unlikely to ever get 100% uptake, as seen with the COVID vaccine. And that means that you can use those people that haven't had the intervention as a natural control. However, there is a risk of selection bias because those individuals might all have a similarity between them, which is why they haven't had the intervention that might impact on your results. So it's just being aware of that. And then the final thing that you can also do is something called a crossover design. It's a little bit complicated, not used overly commonly in practice. And this is pretty much where you have two different populations and two different interventions, and then you kind of swap them over. But you need quite a long time period for washout periods, etc. And it's more commonly done for longer term conditions with short term interventions. So not done very often. So if anyone has any kind of interesting thoughts about ethical kind of considerations and study design, if you want to pop it into the chat and then we can have a look at the end. So if we move on to think about context, now Jess has mentioned this as well, thinking about local context, and it's obviously a really important concept when we're thinking about issues in global health, and we are going to go on to talk about this a little bit more in the next session as well. But this study I thought just kind of nicely highlights some of the kind of the implications about thinking about context, and I thought it might be nice to get us thinking about the importance of it as well. So firstly, if we're thinking about how you design your intervention, you want your intervention to work, and ultimately that means that it has to be both feasible. So practically, from a geographical point of view, from resources, money, etc. And it also needs to be acceptable. So that's thinking about your local, cultural and societal norms. And the authors of this study sum this up quite nicely actually in their introduction when they say about helicopter evacuations, high-cost surgical centres, not feasible in low-income societies. And what they're basically saying is that the scoop and run system that might work really well in the context of, for example, the NHS, isn't going to work if you pick it up and dump it in this context. And it's really important to think about these things when you're thinking about your intervention. And then secondly, we need to think about our study design as well. And obviously context is going to have implications for how you design your study. So first of all, if we're thinking about data collection, and local context can have some implications for this. And that might be in the completeness of the data you can get. It might be the type of data you can collect, or it might also be in the kind of the amount of data you can get altogether. And you might need to adjust your methods to be more appropriate for different contexts. And the authors mention this in sense of the due to local cultural tradition, local autopsies weren't performed on fatal cases. And what that basically means is that, sorry, I just got a notification then. What that basically means is that there was some potential for a limitation in the amount of data that they could have. And obviously you need to be aware about these things from an early stage, because then you can adjust for that within your study. And like I said, that might be changing methods, but it might also be thinking about different statistical analysis, or even maybe just needing to change the outcomes that you're looking at. Now, interestingly, this study also mentions it from the other point of view as well. And it mentions, they're talking about how one of the limitations of this study might be that there was a high number of like unregistered pre-hospital deaths, which would obviously affect the mortality rate. But then they mention that actually, because of kind of prevailing religious beliefs in the area, that people who die have to be found and buried as soon as possible. And they talk about this in context of knowing kind of local leaders and health services, that actually they can be pretty confident that isn't a limitation for the study. And I think it's just interesting to also see how understanding local context can also help you as well. And then we also need to think about how local context can impact on results directly. And that might be, for example, thinking about over time. So this study obviously ran through 1997 up to 2003. And that means that there are implications for that. So for example, in this study, they showed that there was a big increase in burns mortality. And they actually found that this was because coincidentally, there was an increase in self-inflicted burns in young women in 2003. And by understanding that change in local context, they're therefore able to explain kind of variations in their data. And then the other thing to also think about, like Jess was talking about, is your patient journey. And obviously, the patient journey isn't just one action or one intervention. And there's all the different stages of the patient journey can ultimately impact on what your outcomes are going to be. And that you need to understand how that local context is going to impact on your patient's journey, because that might also then impact on the results that you are looking for. And you might need to explain that in your data. And then finally, we need to think about cost implications as well. And the authors of the study say that actually this was quite a low cost intervention, and they state something like a per case cost of less than $200, which, first of all, interesting concept about what value, monetary value, do you place on mortality and morbidity? And secondly, it's also important to think about local context, and especially indirect costs, because that can have a big implication for whether or not your intervention will be successful over a long period of time. So, for example, in this study, with the 2-day sessions for the lay people, teaching them basic life support, it's also important to think about other indirect costs, such as kind of loss of earnings, childcare, food, accommodation, travel time, all of that, etc. And it's important that we are aware of all of them, because that might also change whether or not your intervention will work. So a very quick whistle-stop tour of thinking about context, which is obviously a big topic and very important. So thank you for listening. I will pass back to Jess and enjoy the rest of the interviews.
Thank you, Beth. So next up, the kind of second part of the session is moving on to our guest speakers. So we have 2 guest speakers tonight. The first one is Melinda Narendra, who is here tonight. There is a pre-recorded interview video which we're going to play, but she is available for answering questions in the Q&A at the end. So she's an emergency medicine consultant, acute medicine consultant who works in Malawi. So she's going to share experiences on implementing changes in her own emergency care system. And then we've got Gabin Mbanjumucyo, who actually works at King's College Hospital, but is a Rwandan trained emergency physician who's got an interest in global health and ultrasound. So we'll hear from Melinda first, and then we'll hear from Gabin, and then we'll do the Q&A at the end.
Good evening, ladies and gentlemen. My name is Melinda Narendra. I'm from Blantyre, Malawi, called the Warm Heart of Africa. And I work here in emergency medicine, mainly adult, but also mainly looking at emergency medicine as a whole, and working in the academic section as well as the service section. I'm originally specialized in internal medicine, one of the pioneering graduates of our local university. And as I was finishing my specialization in internal medicine, there was an apt need for us to actually improve adult emergency care, or acute care, as you'd call it. And I was asked if I would be interested, and it had been something that I'd always loved. Whenever I was on call in internal medicine, I seemed to love being in the acute ward. And so it was natural for me to gravitate towards emergency medicine as I was being asked to come and help lead this initiative. Mind you, it was quite a big stride, because during that time in our hospital, doctors did not work in the casualty or emergency room, as we're talking about, we were always found in the admission wards of either medicine, surgery, obs-and-gynae, and pediatrics. So who was in the, what we call casualty or emergency room then, were clinical officers and medical assistants. And that had been this case for over maybe about 15 or 20 years. So when I was being asked to go there, in reality, I was becoming the foreigner coming into somebody else's land, especially more so not just a general doctor, but a specialist coming to a place where people had been managing the emergencies as much as they could. It was quite a change in my career pathway. My first lesson as a specialist in Malawi was to realize how different things are when someone comes to the hospital and you're starting from scratch. Starting to look after an undifferentiated patient is very different from when you have actually sorted them out and then ordered them off or sending them to other specialties. So my first lesson was to humble myself and learn about basic things done well, reduce my expectations because I'm a doctor, and then my colleagues were not doctors, they're clinical officers and emergency medicine care practitioners, and therefore my language needed to change in how far I would be able to talk to my colleagues as we look after patients. So as a female doctor, there were quite a number of challenges that I faced. First, I came into leadership as a young specialist, and I had older people working in that department who had things going on, doing well, managing several number of patients. I must admit that was the first cultural shock as well, is to understand the workload in the emergency department, which can be underestimated when you're in service specialties. So I tried to understand why things were done as they were and to make sure you're on the game, looking after the queue, attending to everyone's need was a good job. So the challenge I had as a young leader was probably about professional respect. As women, our culture is still paternalistic, and there I was having to lead a team that had senior men in leadership prior, so I learned how to communicate differently. I also had to learn to appreciate that if I say things once, I may have to say them 7 times before they are done. Then I also learned how to use patience, but also I needed to show my ability to do things. So sometimes I had to do basic things like even carry a patient to the bed. And over time, I earned my respect by being able to do basic things as well. I was also creating a completely new patient pathway. We were also creating a new documentation system. Everything was new. We're introducing resuscitation. So there's quite a lot going on. And it was very useful to harness mentors, plus also other senior leaders in the other well-known specialties who would then come and help emphasize on the professional aspect. Yeah, well, I must say there was a bit of naivety because, you know, as young people, we think it's just what we think it is, but over time we realize, oh, this is bigger. So what was helpful was indeed the collaboration between those this was a public hospital, which is also functioning as an academic hospital. So the wisdom of the functioning management and academic leadership provided a platform where various emergency care providers from the UK, from the US, and also a bit of South Africa were able to come and also provide us some guidance. But also we had the pediatric emergency department that had also been transformed to give emergency care. So harnessing the local experience, collaborations locally as well as internationally, and also tapping into initiatives. So I'll give an example. At that time, the African Federation of Emergency Medicine was just started. It was amazing when Prof. Lee Wallace reached out to me through the academic circles and said, hey, come through. And he connected me to a number of other African emergency medicine pioneers. So we're able to share experiences among us. Key aspects that allowed us to model our adult section of the emergency department from the pediatric emergency department were the triage system. Much as the adult triage system is different, and for us, what we did was we made a hybrid of the Manchester and the South African triage system. It was evident that our communication needed to be familiar to the local context. So we actually utilized how they communicate triage categories and danger signs into the adult section so that we could be able to emulate that. The 3-tiered was actually advised from knowing that, or rather than Manchester and South African triage are all 4-tiered, but we decided to be 3-tiered so that we can indeed optimize and role model the pediatric section, but also at that time there was some training from Quick Check on WHO. So that's a good thing. Documentation was also pertinent of key indicators that allow us to track our performance, but also communicate as we're looking after patients was very useful. The other aspect was also just organization. Is how do we organize ourselves? Do we concentrate, focus on making sure we have high standard resuscitation care? Or should we optimize sorting, triaging, and then early recognition of life-threatening conditions, and then optimize the rest of the care towards specialty services like internal medicine, surgery, and gynae? As a single doctor in the department, though I was also a consultant, there was no way I could provide all that, especially the resus care. Therefore, we optimized that in saying, look, we need to have an admission unit, which is unusual in an emergency department. So the pediatric department had an admission unit within the emergency department. So we modeled that and created admission services for medicine, surgery, and obs and gynae within the emergency department. That facilitating some form of backup for me, where registrars and medical officers from these services would provide a higher level of resuscitation or medical care that would not be possible with the team that I had within the ED. Pre-hospital services are still on the developmental phase, but what we can say is that the presence of a formal pre-hospital service is now evident and recognized. We see more ambulances that are being used for emergency care versus inter-facility transfers. The emergency medical service, which was formal in the public sector, is still responding to injuries, and there's a formal access line that people can call to. However, the capacity has still remained, is not reaching everyone yet, but is definitely making an impact. And I would say that the informal pre-hospital care service still needs to be strengthened and encouraged because of the dynamics of how long a system can be established. Plus also in our low and middle income countries, it's more about funding streams and competing interests within the health system. So I would say we've managed to show that we do have an ability to have an emergency medical service. We have personnel working in there, which is exciting. And we've got a call center, which is lovely. And we're able to provide the service to the community, even though it's just injuries. The other thing I would add about pre-hospital care is that, as you've said, over 2 years, the dynamics in the social aspect of life. And that does change the dynamics of our health system. And what we need to learn is to respond to that. So I'll give an example in injuries where the vehicle numbers have increased on the roads of Malawi. They form more markets on our main highways are there. So we need to understand that in pre-hospital care, we need to improve in collaborating with other sectors of legislation, police, among others, so that we can understand that the value in reducing injury-related mortality or morbidity has got to do with quite a number of things other than just the response. I think the scoop and run is more realistic at the moment, looking at the capacity that we can actually extend ourselves. We still have a very compromised human resource as well as health budget for us to invest into pre-hospital care. And therefore, scoop and run will be pertinent. But however, I would say it is of pertinence that the paramedics that we're training who are usually, so far the first cohorts have all been prior health workers. So from lower cadres in terms of medical assistants, but also enrolled nurses. And they are being transitioned into an 8-week course of paramedic training, and then thereafter seem to be developing more on the job in terms of their skills of emergency service provision. So I would say that we need to optimize more programs so that we can indeed train more paramedics in our setup, but also we look forward to the aspect of having a lot more of advanced life support providers. And that requires more training and more oversight, as well as supervision and mentorship.
Thank you for Melinda for that wonderful insight. We're going to move swiftly on to Gabin.
Thank you, Jess, for the introduction, and also Jessica, thank you for the introduction and your presentation that you made before, and also Mulinda. I'm quickly going to go through just a few insights on global health in terms of and bringing pre-hospital care in the view. Just because of interest of time, I will be a little bit quick, and I'm happy to answer the questions. So we have covered this. Jess has covered this before, that most of the injuries are usually in low and middle income countries. There are so many factors that contribute to this, but I'm going to quickly speak through one of the studies that was done in Kigali, in one of the big hospitals, actually the major trauma center, where they looked at injuries that were brought in hospital by the local pre-hospital cares. So that's the details there about the patients that came in through, and you can see down there going down to the mortality in the department, how many were recruited. Of course, a few files were lost, limited resource settings. Keeping records is one of the major challenges, so studies might not be accurate as they are, but you will be able to interpret some of this. I'm happy to share the link to the study that was done. I'm going to cover about the major findings that we found. So we looked at all the injuries that came in. This is more demographic studies of just descriptive studies, and we didn't go into linking and causes. But look at what we found, and this is where the global health part comes in. Compared to London, I've been in London for the last 2 years, and we have a different epidemiology of trauma. So if you look here, we have 71 road traffic accident. Fine, you might argue that most of the traumas, most other places, we have a high number of RTAs coming in view. We didn't have a lot of penetrating gunshot wounds. Are quite very around. Is a very safe country to be in. We had animal bites and all those. But when you come to road traffic accident, when you magnify what we found in the road traffic accident, there's a lot of motorcycles as a means of transport, cheap way of transport and quick, fine. That explains why you might have a lot of motor vehicle and motor vehicle and motorcycle accidents. But when you look on the other aspect, we had a lot of pedestrian 15% of all these injuries were pedestrian. This is unlikely that you see this in the high-income countries. So this brings in some of the things that you might want to look at in terms of pavement, pedestrian pavements. At that time, that was a country that's bringing up, is coming up, the economy is growing, there are roads being built, but yet the pavements are not being built as fast. So we are concentrating on roads. The traffic lights, pedestrian crossing are not well respected. And in developing countries, the average population of Rwanda is 25 years. These are young people with an upcoming economy. So might not really respect all the rules that are out there. So that's one of the policies that you have to look at when bringing policies, not about only building the roads, building the hospitals also, but what is the population doing? How old is the population? How easy will you teach them? So look at that motorcycles, pedestrians here, it's not very safe to walk on foot. Actually, it's safer to be in a car than to walk in Kigali, if you look, if you conclude from this data. When you look at another point that was a little bit concerning is we had craniofacial injuries. You might argue that fine, people don't put on helmets, but Najibu is here, and anyone who has been in Kigali might just agree with me that in Kigali it's mandatory, you have to put on a helmet. But it comes in one other thing. It's a helmet that you have to share. You don't have your own helmet. So when you see such a study of more than 50% having craniofacial injuries, that's another insight of public health, global health, that fine, everyone is putting on a helmet, but simple things as teaching people how to put on a helmet correctly, we change everything here. That's a motorcycle. I used to ride one of these when I wanted to go to work quickly. But this is the view in Kigali. You can see the motorcycles, the vehicles crossing all over the place. You can see motorcycles being hit all over. They can easily be hit, but if a pedestrian is crossing here, there is no pedestrian crossing. They are also going to be victims. So this is one thing that when you're building hospitals, everyone thinks, okay, we have to build hospitals, you have to bring in very expensive ambulances. But you forget things, simple things like road safety rules, teaching the population, fine, the roads are fine, you have everything that you need there, but have you gone by the basics? When you look here, all the intubated patients in the department, all of them were trauma. So this is draining a lot of resources from the hospitals. If you have 52% of everyone in the department, everyone in the hospital being intubated secondary to trauma, and it's mostly preventable, high number being pedestrian, that's very, very huge. So going back to the slide, this is what I talked about. I'm not going to go to the deep in details just for the sake of time. I'm happy to explain. I'll send more details about this study. But you can see again that how much simple things can drain. Let me just bring another thing that we concluded after the study. So look at the difference between these two charts. When you see the accident by province, so Kigali has 5 provinces. Kigali has about 1 million. That's about 10% of the population of the whole country. But look, all the trauma, almost 56% of everything is happening in Kigali. But you can see mortality, only 9% are dying. Let me explain to you why all this is happening. So fine, people are getting a lot of trauma, but not very people are dying. So you are likely not to be involved in an accident if you're outside Kigali, but you are likely to die if you had any major trauma outside Kigali. So if you look at this, and this is where Prehospital comes in, the numbers have gone up. This is an old slide. I could not get an updated slide in hand in time, but all the major, the ambulances are mostly concentrated in Kigali. So that's where Prehospital comes in. You are likely going to go into hospital because all this, they are peripheries, and the next slide concludes to all this. So most ambulances are in Kigali, and the tertiary, the major trauma center is also there in Kigali. So looking at the tertiary, how the transfer, I think just covered all this. Come from community, so you are on the you are at the peripheries here. You have to go through a community, take you to district hospital, which will transfer you eventually to Kigali in a referral hospital. So all that time you're losing here, that explains all that mortality that's happening. So you have to go through all this to arrive to Kigali where all this happened. So you understand a few things that maybe having spreading the pre-hospital, spreading the trauma centers out there, that will have a huge impact on what you are doing and how you can improve. So when you're bringing about covering, concluding to this is approaching global health, fine, there are the basics. You need healthcare workers, you need hospitals, you need pre-hospitals, you need all this, but the context has to come. When you look at Kigali, motorcycle is a big threat to everyone there in terms of getting involved in trauma. It's quite safe, literally. In Kigali, it's very rare that you get any gunshot wound. Everyone gets scared. You never see a gunshot wound. You never see a stab wound. It's very rare. But motorcycles, is almost half of the department. Every day is a motorcycle involved. And pedestrians are the victims just because of simple rules that can be changed. And putting on helmets, you get all these people. They only had 5 neurosurgeons catering for all this. Literally, they are in hospital 24 hours 7. So just small policy changes, spreading all these care out there can easily change all this. So that's my references that you can, and I'm happy to send a link to the article and more of this. And thank you for your time.
Thank you so much, Gabin. So now we've had both the guest speakers, I'm going to open the floor up. Does anyone have any questions about either the presentations or just any comments from the themes of the day? You know, GB, you look like you want to say something.
I put my hand up. I didn't know.
I didn't see that yet.
Didn't want to be one of those. Well, thanks, guys. It was a fantastic evening. So, you know, really well put together. And, you know, Gabin, Mulinda, thank you so much for joining us. Mulinda, thanks for putting the response around triage and the challenges you've had in the text. I wonder if you could maybe spend just a couple more minutes expanding on that, really. I think we sometimes take it for granted with the systems you already have, but clearly the challenge you have in trying to get improvement work and system strengthening work done, it seems a lot of it is about culture, but also the human resource capacity and the collaborations and partnerships to do that. I wonder if you could expand a little bit on that, Melinda.
Thank you, Najib. Indeed, focusing on actual change management, we could call it, has got to do indeed with understanding culture and human behavior. Very important, I think, something that we overlook, but also resources, as also mentioned. So when we look at triage, I would say that triage is our gatekeeping, sort of like also some form of hospital reception that allows us to be able to engage with the community. And what I've noticed in our hospital is even just when we look at designs of hospitals, acceptance of triage will be based on how you have actually placed your emergency department. So our emergency department is housed in the historical administrative building of the hospital, which actually means that people are so familiar with it, and there's never been a replacement of a reception for the hospital. And therefore, it means that we act both as a reception as well as an emergency department. So complexities of managing, sorting, and directing people, and then actually triaging people tends to be an interesting interface between health workers and community. And that's why I feel like investment of basic things done well will be better, but also it's a multi-sectoral approach where you actually look at where are we doing the triage? What else as services are we doing in the triage area? And then also saying, look, what sort of staff are we having?
So I feel like for us, that has been the main stumbling block, that we're handling quite a lot of things at the same time, other than just being an ED, we're a hospital reception, and then it complicates things. When we look at the process itself, I would say, indeed, as we've brought in MEDs, as well as also nursing programs that come in through the department, students, among others, I feel like we are at a level where we can actually improve things. The bringing up of POCUS in the ED, bedside point of care tests, definitely makes a difference in how much you can actually optimize triage systems and optimize triage nurses or triage systems as a whole. So that's one sort of area that I would say we should explore in various settings, and others have done as well. And it's nice to hear about the impact of automated diagnostics, because definitely can make a difference. I think in summary, I would say that's it. The other thing is also the tools for triaging. So apart from just the skill, is the tools. So we were lucky to have an electronic medical system that we sort of designed for utilization. It makes a difference how people accept things if they don't have to write too much. So that's another aspect, human behavior, is how can you make things simple and then keep the information. Thank you.
Well, thanks, Melinda. That's, fantastic information, I think. And, as you said, trying to separate out the basic function of reception and triage into two different streams. It sounds simple, but I can imagine not straightforward when there's other limitations and capacity issues. So, no, that's really insightful. Gabin, if I could ask an allied question, and actually this is more to think, because you're currently in the UK, as you see now, we're suffering with huge amounts of congestion and having to kind of consider the role of re-triaging, because our current triage means that we sometimes can't still see patients in appropriate order. So we're left with a situation where actually experience like those who've worked in other countries might become really valuable. So do you see any crossover in that kind of learning experience as you went through that learning in Kigali and now in the UK? And the second part is linked to your presentation of data. And did policymakers listen to you guys around trauma before the data was available? Or has data really helped to have that conversation? Because you and I both know we used to see these things all the time in resus, right? But then what really helped to make the policy change? Was it the data?
Thank you, Najib. That's both a little bit challenging questions to answer. But let me start with the second one a little bit. Before, of course, this is a developing country, everything, decision rules, and when making decisions, it's a little bit more cultural. And before data was available, studies started to come around in 2010s beyond. Before in the early 2000s, there were no studies. I think I'm an expert in this. This is what should be done. But now, and actually that's where things, resources were going in the maybe not the appropriate settings, because you judge by your exposure, which is a little bit biased. But with data, and the population of Rwanda is quite young, people in power now are mostly educated through the system, so they understand. And now they are starting to channel resources in an appropriate way, with data leading all the way. And in the last 2 years, just before the pandemic, the police had come on board. They were consulting emergency physicians and on our data, and we started seeing mortalities go significantly down. I didn't put a presentation on where mortality within 5 years had reduced by 80% because of a few measures. That's another study for another time, but they had gone down by 80%. Nothing was done, nothing major in terms of millions of dollars invested in it. It's just simple things, and just from that one. The second question here, the triaging definitely is. When focusing on a pandemic and maybe with what's happening around, is triaging and handling things should be an active process that's always changing and improving according to the needs that are there. It's not a fixed thing, and people should do a little bit of studies here and there and see where we're getting wrong, rather than this is what used to happen and this is what we should keep on doing despite everything that's happening around.
Amazing. Thank you so much, Gabin. I think because of time, we'll probably leave questions there. So just want to say thank you to Gabin and Melinda for those amazing talks, and also thanks to Jess and Beth for your presentations as well. We do have a QR code which is links to feedback and planning forward further sessions. The next session will more than likely be in the new year, and it'll be focusing on system strengthening and health partnerships. Obviously, if anyone else has any kind of follow-up questions, then feel free to get in touch with us. We also have the Twitter, the handle, and the website at the bottom of the screen as well, so you can get in touch with us through that. So thank you very much for everyone attending.